I'm Cassie. I'm one of the nurses here at NRM, and I'm here with Dr. Murray. We wanted to talk a little bit about PCOS, which is one of the more common causes of infertility, and go over some commonly asked questions about PCOS. So, Dr. Murray, what does PCOS stand for?
So PCOS stands for polycystic ovary syndrome. It's actually a little bit of a misnomer because the cysts are actually follicles that haven't released their eggs, but in common parlance, that's what it's been called for many years. So,
And how would I know if that's something that I have? How does it get diagnosed?
probably the most common symptom associated with PCOS is a lack or a lower number of menstrual periods per year, generally less than 6 menstrual periods per year. Other symptoms associated with it can be excessive hair growth, facial hair around the breast and the abdomen. Sometimes there can be acne. People can struggle with that. And about 60 to 70% of women with PCOS also struggle with weight issues.
Can you still get pregnant if you don't get periods?
Yes, the ovaries contain normal eggs just like any other ovary, but it's the actual hormones surrounding the ovary and within the ovary that make it hard for those eggs to release. And so if you're having less than 6 ovulations per year, obviously your chances of conceiving are less just based on that.
What would the treatment be if I do have PCOS and don't get regular periods and want to get pregnant?
So for women who aren't attempting to get pregnant, typically what we want to do is institute regular menstrual cycles, and that can be done with generally birth control pills, other hormonal options. But women who are trying to conceive, our best options are either oral or injectable medications that correct that hormonal milieu and allow for the eggs to be released in a more timely fashion. Typically, Clomid and Letrozole have been the first line agents. They're oral medications that convince the ovary to release those eggs in a regular fashion. Sometimes people need stronger medications, and those can be injectable hormones that, again, can cause the ovary to release their eggs. And once that happens, then the pregnancy rate is very similar to women who don't have polycystic ovary syndrome. It's simply a matter of getting the eggs to release properly. And once they do, the pregnancy rates are very similar.
Are there side effects associated with the treatment options?
For the fertility medications, I think the main side effect is that the ovaries can go from under-responding to over-responding, and so there's a risk of multiple gestations when we use those medications, so the risk of twins and sometimes higher order multiples can occur using those medications. But other than that, sometimes people will comment that the medications make them feel a little more irritable, sometimes some breast tenderness. But those are the main side effects associated with them.
And if I've been told I have PCOS, if that's a diagnosis I get, is that something I will always have?
It's interesting that PCOS can wax and wane throughout a woman's reproductive life. But typically the symptoms do start to go away in the early to mid 40s. Women will notice that their periods become more regular. And so it's a syndrome that can be there or not be there based on what's happening with the rest of a woman's metabolism.
So if I were to schedule a consultation because I think I might have PCOS, if I'm not getting regular periods, if I'm noticing weight gain, acne, or other symptoms that you mentioned, what would that look like to go through an evaluation if I were to see a physician for this?
I think that's a good question because I think with polycystic ovary syndrome, we do some blood work evaluations as well as ultrasound. It's important to note that there's not any one particular diagnostic test that confirms polycystic ovary syndrome. What your clinician will want to do is to rule out or make sure that the symptoms you're having aren't related to something else. So for example, we would check thyroid function, because sometimes women with low or high thyroid activity can have fewer periods. We sometimes check male hormone levels, because we want to make sure that the source of the hirsutism and acne isn't from a tumor or some other source of those elevated hormones. One of the complicated issues associated with polycystic ovary syndrome is something called insulin resistance, which means that women with PCOS typically have higher circulating insulin levels, and that can cause, that can complicate the weight issue as well as ovulation. We may check a woman's response to insulin over the years with a test called hemoglobin A1C. And that's something that we may recommend some supplements for, such as inositol, which is an over-the-counter supplement that can help regulate insulin levels. Sometimes women will be started on agents such as metformin that can lower circulating insulin levels. And those sorts of things can help improve ovulatory function. Ultrasound is a big component of diagnosing PCOS, because we will see a typical pattern of multiple follicles within the ovaries that are sort of a mid-range size that haven't been able to ovulate or release yet. So ultrasound does give us a pretty typical picture of polycystic ovary syndrome. Another test we may do is something called AMH, or anti-Müllerian hormone, which again is a substance made by resting eggs in the ovaries, and women with PCOS will typically have a much higher than normal AMH level. So an evaluation would really involve blood tests and an ultrasound, and with that information, along with the symptoms and signs that the patients have brought to us, can usually lead us in the direction of making that diagnosis of polycystic ovary syndrome.
Okay, thank you.
You're welcome.
If you have additional questions about PCOS, you can email Dr. Jenny Brown at nrmvt.com, or you can call our office or go online and schedule a consultation.